Good morning, everybody. Today I will give my talk about shoulder instabilities, which is very common in fields of sports medicine and among the athletes. So I have nothing to declare, but I want to thank to my all contributors and my international affiliations that really helped me to improve my career in shoulder and elbow perspective. If you want to have more detail, you can scan this one and then get in touch in terms of all your I will be very happy to answer your questions if you reach me as well. Just before go in deep, I just want to say, I always say that it's a great honor and pleasure for me to be part of that great family, Aspetar family. It's like my home. It became my home very quickly. And hopefully in the future we will do a great jobs together, hopefully. So these are the books that so far I edited about shoulder. One in 2017, 19 and 21. And last year I already finished one book project about the shoulder. So hopefully you can go online and enjoy. If you have any questions, just reach me out. This is the overview of my talk. I will start classically with the history of shoulder instabilities, and then I will talk about not the boring part of the shoulder anatomy of shoulder instabilities anatomy, which is a little bit unique, and biomechanics of dislocations, pathoanatomy, pathogenesis of dislocations, some risk factors, and how do I decide when I treat the patients, and some challenge cases, not the easy one that I brought here to share with you guys. So today, briefly, literally, I will talk about GH. GH is not Gazi Huri today. It's going to be glenohumeral joint. So definitely. But before then, we just published a paper. You know, like social media is very popular nowadays. We published a paper about, like, just a quick reminder. Don't believe everything that you watch in YouTube or any social media, because we reviewed 300 videos about shoulder dislocations last year and published in Arthroscopic journal, and only 1 out of 300 was excellent. So 299 was completely including very mild or some wrong informations. So always stay in the right side in terms of the evidence. So let's start about the history. The history, like shoulder instability or dislocations, is very long history, like more than 1 century. It was first described by Dr. Arthur Bankart. He's a British surgeon, orthopedic surgeon, and he first described the anterior inferior capsular damage after anterior inferior shoulder dislocations. And then after that, in 1923 till to 1990s, like 70 years, there were no any updates about shoulder instability in the literature since Dr. Burkhardt described a new concept of Hill-Sachs lesions, what happens to the humeral side after the shoulder instabilities, and also he is one of the pioneers of arthroscopic shoulder Bankart repair guys. So literally, Bankart first described the glenoid side of the instability, and then I think I can use this one. It's better. No, and then Burkhardt described the humeral part, and in 2007, Dr. Itoi, he's a Japan surgeon, orthopedic surgeon. He's a very famous shoulder surgeon as well. He described both of them, the engagement of the humerus and the glenoid. We call it track philosophy, on track or off track. And now still there are many debates about the shoulder instabilities in terms of how to treat them, even how to diagnose them. So why do you think it is a unique joint? It is a unique joint because it has the maximum range of motion among all the other joints, with less bone support, which more soft tissue support, and has a very complex biomechanical. So if we need to talk about shoulder instability and dislocations, for sure we need to talk about soft tissue balance, definitely. So all the audience now in the salon, I see your face, you are very comfortable, you are not dealing with your shoulders all in their original place. You know why? Because luckily we have many stabilizers of our shoulder. We can divide it into two: dynamic stabilizers versus static stabilizers. The most famous one is the labrum and the glenohumeral ligament, which acts as a static stabilizer, and bone and the negative pressure are the main static stabilizers of the shoulder. On the other hand, rotator cuff and the biceps tendon are the dynamic stabilizers. So they all work together to make your shoulder right now in its own place. In different angles, it works different. But unluckily, the less effect is the bone. Why? Here, I can say, like the glenoid fossa and the humeral head, they are not the perfect couple like Laura and Hardy. They always have a very, very limited engagement and the contact between humeral head and the glenoid. So when we check this one, I can show this, yeah. Here, most of the glenoid is like epicentric, engaged by the humeral head. The humeral head contacts mostly the center of the glenoid, and the rim of the glenoid you're gonna see is out of scope, out of touch, out of contact of the humeral head in static shoulder. What happens when shoulder moves? Do you think this engagement increases? Definitely not. It doesn't increase on the right upside. Only you can easily follow the purple lines. The center of the glenoid is not touching anymore to the glenoid, which means that it has a partial connection. So in terms of like glenoid diameters and the humeral head, there are very limited contact surface between these two bones. So literally, when you put your arm in 60 degrees of adduction, only 89% of the glenoid surface is engaged. When you increase in 90, a little bit more abduction, 83. When you increase it like 120 degrees of abduction, it makes like 82%. And when you go, this is the most vulnerable position, as all we know, for the shoulder dislocation, has the least engagement, least contact between the humerus and the glenoid. That's why our shoulder dislocates in that position that much. So when we get all the average glenoid surface contact is 93% of the glenoid bone is only contact with the humeral in our all even dynamic and the static version. So this number is also used for the on-track and the off-track measurement, which is an important. So what do you think? The area out of that green surface is useless? We have an extra glenoid? Definitely no. Definitely no. We just all the soft tissues attached to that part. So let's switch on the soft tissue stabilizers, which are more important than the bone stabilizing. So arm at side, now currently, all we are doing the same. The superior glenohumeral ligament and the negative pressure are the main stabilizers of the shoulder. When we start a little bit like mid-range for abduction, it converts into middle glenohumeral ligament and rotator cuff are the main restraint factors for the shoulder stability. And when we do abduction and external rotation, the inferior glenohumeral ligament and the labrum are the structures that provides the stability. So how does this, since I'm a surgeon, I'm interested in the surgical cases for sure. How does these...
bakın bu bölgeden
Okay, so this is my project. A couple years ago I finished. It's Shoulder Arthroscopy Atlas. That's an online atlas. So I have a bunch of arthroscopes and here we can easily see this is the subscapular tendon, that is the middle glenohumeral ligament. Middle glenohumeral ligament just lays over the subscap tendon, and it's the resist anterior and the posterior translation in especially mid-range of abduction. When we go down a little bit, we go down on the scope because we need to know arthroscopic anatomy very well if you want to deal with the shoulder instability. You can see easily the anterior inferior glenohumeral ligament, the anterior bundle. This is the most important primary restraint for abduction and external rotation in terms of the fixation. So this cadaver luckily has the Bankart lesion as well. When we go a little bit posterior, we'll see the posterior inferior glenohumeral ligament. And if these two ligaments are torn, our scope goes directly through the axillary pouch, and we call it drive-through sign. When we go a little bit upstairs, we will see there is a slap lesion here, which is also very important because it is engaged with the superior glenohumeral ligament, which is also the most important ligament for superior and the posterior restraint, stabilizing. So we need to know this arthroscopic anatomy very well if we want to do the surgeries and fix how it's going to be the best results. So, shoulder instability, it's really very common conditions. It's the most common dislocated joint across the body. Between 1 or 2% of whole population, I'm not talking about any risk factors, has the risk for the shoulder dislocations. More than 90-95% of the shoulder dislocations occur anteriorly, the rest posterior and the inferior dislocations. And of all the patients who experience, accept all the risk factors, if you have only one dislocation, primary dislocation, you have the risk for the recurrence for 35 to 40% of redislocation. I'm not specified your age, your sex, your sports activities, whatever. If you have one dislocation in your life, the second dislocation episode will happen probably in 40%, which is very high. So what happens when shoulder dislocates? Baker described his classification, and I like this classification very well because it really tells us why shoulder redislocates that much. Only 13% of after first dislocation has capsular tear, which is good, which heals the capsule. The ligaments are pretty fine, and 25% after first dislocation has a partial tear of middle glenohumeral ligament, which is also more or less may heal. But the major vast of the dislocations comes with irreversible injuries. Like over 60% has complete inferior glenohumeral rupture plus capsular rupture plus Hill-Sachs lesions. So that is why, according to the previous studies, which has shown very clearly that after these 60%, more than 60% injuries, all these injuries are irreversible. They don't heal by themselves. That is why it really makes sense that why the shoulder instability episodes recurrence are that high, because it's not healing. That's why there are some studies which support just physiotherapy is working well. Probably it is in Baker group 1 or 2, but if you have an injury, like I'm going to show you, like concomitant injury, like ALPSA, like deep Hill-Sachs, they don't have any response to the physiotherapy. This might be the reason. So if I show this one, if you have an anterior dislocation, it means that Bankart lesion, because we all show the surgeons he has a Bankart, she has a Bankart lesion. Do you think this is similar, synonym? No. All dislocations are not Bankart lesions. If we say all dislocations are Bankart lesions, it means that we don't know anything else. So Bankart is just a lesion which affects the glenoid part. But we all know for instability philosophy, it's a bipolar lesion. We need to figure it out that there is something happens also on the humeral side. So it is after first dislocations, almost 80% of both parts are affected. So we need to go with the glenoid part, and then we need to go to the humeral part, and we need to decide what kind of treatment we need to get. So how do you think shoulder dislocates? Did you ever think about it? So we all know abduction, external rotation, yes, it dislocates. And then in which phase the bony Bankart happens, in which phase the Hill-Sachs happens. So this is a very important question, because some cases has very small heel sucks, some cases have a deep heel sucks. Why? I will introduce how it works. Shoulder dislocations has two phases. The first phase is abduction and external rotation. We call it end range of abduction external rotation. This is the most common position that shoulder dislocates anteriorly, and in that case, here you can easily see the red line is the force vector at the time of impact in that position. It starts from the humerus and hits on the anterior part of the glenoid. In that case, in this phase 1, the glenoid part affects. That's why we see always, if there is a heel sucks lesion, we also see the Bankart. But sometimes we see Bankart lesion without heel sucks lesion. So the first phase is always affects the anterior part of the glenoid. In some cases, if it is medialized that much, it also includes the bone, and it makes like fracture, bony Bankart or soft tissue Bankart. So this is the first phase. And what happens when the dislocation, if you watch a dislocation video, it's very typical. It dislocates, and then it's try to get back, right? It's like a reflex. So it's like when you try to go into the neutral position, we call it mid-range abduction external rotation. At that time, your heel sucks lesion happens. So this is how it happens on the shoulder pathology in terms of the shoulder instabilities. When you get your like 70 degrees of abduction, like 20-30 degrees of external rotation, you just feel the heel sucks lesions happens. So this is a kind of like a cyclus that happens in terms of the shoulder dislocation. So if a sports guy, an athlete, comes for the first time dislocations, probably he has a small Bankart lesion and additional bony, very small, and then even a small heel sucks lesions. But if it is recurrence, all these pathologies definitely increases in a bad way. So as shoulder surgeons, if we are dealing with the sports professional athletes, we need to avoid the recurrence. This should be the first message. That's why I'm talking about that detail about the pathophysiology, because every shoulder dislocations has its own history. We need to know what is going on in his or her shoulder. This is the patient, very typical anterior inferior dislocation X-ray shows less heel sucks lesion, first time dislocation, and immediately somebody, it might be coach, it might be team physician, it might be sometimes sports medicine, or we physicians, or we reduce it, and it comes in very good places. First time dislocation, good reduction, no fracture. Most of the time we are very happy to see, but in that case, if he is a professional, she is a professional athlete, how we are going to deal with this? So in terms of our practice, my practice, before I make my decision for how to treat the patient, I'm not going to talk about conservatively because my topic is a surgical stuff, so more surgically. I have a checklist. So the age of the patient, sex of the patients and athletes, joint laxity, type of sports, if it's in dominant side versus the non-dominant side. And another issue is the concomitant injuries are the main issues that make me to decide for the surgery, and also to decide the type of the surgery, because you will see soon there are many different types of the surgeries that we do in terms of treating these instabilities. In terms of the age, the recurrence rate among young patients, young athletes, young population is much higher than the old ones. So if our patient is less than 20, the recurrence rate will be more than 90%. We need to be very clear, especially in sports athletes, even they are in season, and if they are overhead athletes, we need to be more aggressive to treat them even in season. But if he's a football player, not a goalkeeper, okay, we can do it on the off-season period, but we need to remind them definitely about the recurrent rates. If the patient is over 50, experience the shoulder dislocation anterior inferior, luckily the recurrence rate is less than 50, but in that cases the rotator cuff tear as a concomitant injury is over 60-70%. So it is really very, very high risk of recurrence if the patient has a rotator cuff injury plus Bankart lesion. We experience in the emergency rooms a lot, especially in young. When I reduce the shoulder, it really gets very stable, but over 50, 60, first time dislocations, I reduce it and then I turn back and dislocates again. I reduce it and dislocates again. It means that it's not just the instability of anterior inferior, and also the patient has the loss of superior support, which is rotator cuff. In terms of the gender, male has this advantage as always, especially after 2 years, first time dislocation. So it should be, we should talk about, like when we talk with the patients about recurrence. After 2 years, you have the high risk for the dislocation, and after 2 years, you have a plateau. The risks doesn't increase. So first 2 years is very important if you want to talk about the patients. How about the hyperlaxity, hypermobile joints? It's also controversial. I cannot say that it's completely a risk factor for shoulder instability or dislocations, but I can easily say that, like, there are some papers about that. They dislocate hard, but their healing process is worse than the normal population, which is not published. This is just my observation in that patients. But if hypermobile, of course, it's a kind of risk factor. We need to accept it. In terms of right or left or dominant or non-dominant, the literature is also controversial about. Some literature say there is no difference. Some literature says the dominant side, if it's a contact athlete, has a increased risk for dislocations. So also I put it in my list when I decide for the surgery. Type of sport is a very nice study, level 1. They included 131 professional athletes. They have first time dislocations and divided into non-contact and the contact athletes. For sure, it's not surprising that contact athletes has 2 times more dislocations rate than the non-contact athletes. So as a surgeon, if we decide to do something in surgical case, this is a very important slide for us, because completely changes our surgical, not indication, type of surgery. If the patient has a Hagel lesion, Hagel means the detachment of the anterior inferior glenohumeral ligament that I show in cadaver is detached not from the glenoid, it's detached from the humerus side. So this is probably most misdiagnosed type of anterior-interior stability. So please keep in mind that Hagel lesion is completely different and completely different treated. Mostly open surgical procedures is needed. If the patient has a Hagel, you need to make an MR arthrogram to figure it out. Another issue is abscess lesion. This week we have a very typical, the same lesion as a professional athletes. It means that the severity of the injury is very high, because there is not just only the peel of the labrum, including the periosteum. So it's like very high energy trauma. So it also changes our indication. As I mentioned, if there is an concomitant injury as a rotator cuff, we need to fix the rotator cuff as well after dislocation. So most commonly it happens like articular damage after dislocations or bony Bankart. We need to figure it out. And also for sure heel sucks lesions. Heel sucks, among all, heel sucks is the most common one that we just check, as Itoi mentioned about the on-track and off-track lesions. Have you ever decided about what is, it's a very confusing concept. It's not easy even for the radiographers, radiologists as well, to say it's an on-track and off-track lesion. I'm gonna say why. So I just make, our car is glenoid and the road is humerus. So the axle of the car, in the purple line, is our glenoid track width. So car is glenoid, road is heel sucks. So road is heel sucks. Yeah. If the axle of the car is smaller or the groove on the road is bigger than our car, definitely our car will drop into the groove. So, and then it's going to be locked. If it's locked, we call it off track. Luckily, if our car is bigger than the groove, the hole, our car will not drop into the groove. So in that case, we are going to say it's on track, which is good for the patient, also for us. It's not going to change our surgical time will decrease and whatever, and also the surgical technique will be easier for that. So we need to think about this one like this. The left side was our car, the right side is our road, and if this happens, our car just drops into the groove. So this is the off track and on track. But always there is but in these kind of complicated descriptions. If the patient, you will easily see in the most left side is on track, like white and black, right? In the right side, in the mid box, there is an off track lesion. There is no controversion. But I want to raise a question: if even your car is bigger than your hole or your groove, you have a small groove, but the placement of the groove is just under your wheel, you will also drop in the groove. So this is very complicated. This is not easy. This is not easy to see in radiological images, maybe, because we call it medial Hill-Sachs lesion, the location, and they are also off track. Even they are small, they are just under your tires, and poof, you just fall into the groove and you lock your shoulder. So this is the paper that we published with Üstün Aydingöz. He is a radiology professor and a good friend, also a good friend of Marcelo, probably. So you can go this paper and track how to assess an on-track and off-track step-by-step technique. I would be happy if you are. We use the Z-MRI, and also here we have Z-MRI. Has many advantages over CT according to our paper. So this is me. At the end of the day, I always think about like this, you know, in some cases, the performance, the atlas, indications, what is wrong, you know, because I need to fix many things, like the glenoid defect, the Hill-Sachs defect, and also, as I showed, it's not sometimes like black or white, some gray, this we call it translation of the humerus, which can be dynamically examined during the surgery. We need to examine it inside the surgery. All of my case, when I go into the shoulder joint, I just make a static examination and then dynamic examination. I just push the shoulder on the anterior part, even it's on track. Sometimes I see the track is engaged. So there are many issues that I need to figure it out and fix it. So if you, the issue nowadays, like because of this Hill-Sachs issue, people say, okay, if you have a Hill-Sachs, just fix it. Don't deal with an on-track and off-track. It's very easy, particularly in the professional athletes. If you have a Hill-Sachs, just apply the remplissage. This is one of the approach. Or if the patient has a Hill-Sachs, why do you try to increase the size of the glenoid? So this is another question in my mind. So, it's very hard to follow slide. That's please don't try to read it. Because I just copy paste that slide from the consensus, because this is like how our mind look like when we deal with the shoulder cases, instability cases. So I will make it a little bit clear for you. So these are the whole treatment options that I deal with in shoulder instabilities. I can do only soft tissue repairs like Bankart lesions, Bankart repairs, plus I don't like to use the Bankart repair. I think it should be anterior inferior glenohumeral reattachment surgery is better than the Bankart. So if you want to talk about anatomically, and also we can apply remplissage as a soft tissue procedure. On the other hand, if we have, it is all my cases, if these patients have a big glenoid rim fracture, arthroscopically I can do it and screw fixation. Also is a sort of fixation technique and treating technique of the shoulder instabilities. And also if the patient has a big, I'm going to tell how big glenoid defect, I will go with the Latarjet procedures, even open, even arthroscopy, but arthroscopy is a little bit, has some complications in terms of the exposures. This is one of my case, has a very well bone healing. And if the arthroscopy, like the Latarjet fails, or in some cases now it become very popular, I just use an glenoid bone graft from iliac crest. This is the bone block technique. So these are all the techniques that I use in terms of dealing with the arthroscope, except one I'm going to show you later on. So even among all these type of different surgeries, would you still perform only isolated Bankart repair in that cases? I don't think so. We need to figure it out. But isolated Bankart repair is also very popular, and also the technique that I use in some selected cases. So how I am doing? So this is, first you need to mobilize. You need to mobilize your labrum, and you need to refresh your bone. You need to have a good bloody bone. In terms of having, and then after you mobilize it, you just pass through the suture passers under the labrum, and then you put your first anchor. There are many different types of anchors that you can use. So in that demonstration, I used 3 different types of anchor. This one is the all suture anchor, which has no any even metallic or even biocomposite ingredients. It's just the suture anchor, and then so I just wrap it. You can easily see here on the left upside, I'm dealing with the suture management, and then I do my sliding knots, and my knot is coming, and I really love to watch this part of the surgery. It really makes me very happy because the reattachment is very secure, and then I cut the ropes. Sutures as well, and this is I go at least you need to put 3 to 4 anchors just just below the diameter of from 3 to 6, I can say. So this is another type of anchor. Just want to make sure also for the audience, for the internet followers. So this is another one. I didn't put any knot on that case. I just hammer the anchor. This is the biocomposite anchor. The first one is all suture anchor. This is knotless biocomposite anchor, and the other one I'm gonna show you knotted biocomposite. The third one, we call it peak anchor, and after that we have a very nice suture management is also very important in terms of having a good surgery. So this is my last suture, and then it's all done. What I mentioned about the suture management, we just published a paper last year about how to manage the sutures, because the main problem, especially for the beginners of shoulder arthroscopy, is there are tons of sutures inside a small hole. You need to be very precise not to get them tangled each other. So we described not a new technique, a trick only, a small trick, and published it. And here, even in Aspetar, normally arthroscopic surgery is performed with the 2 portals. Here I perform from the 1 portal. In terms of the clinical results after 1 year, it doesn't make that much difference, but duration of the surgery is 20, 25 or 30 minutes less than normal, I think, which I believe is very important. However, if you perform only Bankart lesion, this is a study, 10-year follow-up after isolated Bankart repair, published in 2019. The instability event is 31, and 16% you have a redislocation, and persistent apprehension 2%, and revision rate 17. I think they are very high. It's very high. It's unacceptable for it's in professional athletes. So currently, what I am using I accept, in the beginning, all patient has a heel sucks, even small, even big. I accept all the patient have a heel sucks, and I do my decisions according to the glenoid. If the glenoid size, the defect is less than 10 or only soft tissue, I treat it in another way. If the defect is from 10 to 15, is another way. If it's over 15, it's another way. When I was a resident, it was like 20 years ago, this number was over 25, but now it's decreased. It's up to 15. If it's a critical bone loss over 15, you need to have something. So in the first scenario, if your shoulder has no bone defect, but within heel sucks lesion and professional athletes, the literature supports to add remplissage technique. Remplissage is a French word, means feeling. You need to feel the defect with something. We feel the defect with infraspinatus muscle tendon. So what happens when we do this one? So it decreases 9 times the risk of recurrence, which is reasonable. And also increase the forward flexion, and similar results, here is very important, to Latarjet procedure without that much complications. So, but the only thing you need to be a little bit more, you have up to 5 or 6 degrees of lack of external rotation if you put something on the posterior side of the humerus, but I think it deserves. If you don't want to do this technique, or if you don't want to deal, there are some other maybe not easier but convenient techniques that you can do with the glenoid side. The first one is ASA. You can transfer, if sometimes like your labrum is very atrophic, or you are like absent of the labrum probably, so you can augment the superior part of the subscapularis tendon with the capsule and put it back on the glenoid part. So this is ASA technique, which is described from Italian surgeons, and also the Roman described BLS technique, the augmentation of middle glenohumeral ligament with the inferior glenohumeral ligament. Also probably it's a very useful and easy technique if you have some kind of like atrophic labrum or very degenerated labrum that you cannot. In scenario 3, I'm jumping from 1 to 3. If you have more than 15% of defect, you need to go with the Latarjet. This is like this, or you need to go with the bone block procedure. I think it's like the easiest indication that you describe for the Latarjet. Latarjet works with the triple stabilization effect, sling effect, bone block effect, and the capsular application, which is very common. Oopsie, yeah, I got the water. So this is one of my patient as well. He has an severe bone defect in the anterior part of his glenoid. So I for sure decided to go with the Latarjet procedure. First, you need to get the graft as a coracoid, and then you need to prepare the glenoid side, and then you need to put 2 screws, not 1, which was the original described before, to increase the rotation stability, and this is how it looks like. Just immediate after surgery, you have a good compression and your bone block is up there, which is that you want to get that result as an anterior Latarjet bone block procedures. So why a Latarjet fails? Most of them fails because of the misplacement. Most of the surgeons, they put more convenient to see is the superior part of the glenoid rather than anterior inferior parts. So this is the main reason that why Latarjet fails. Or according to the implant that they use or application, if you use only one unicortical screw, it fails, and you need to do also capsule repair if you want to increase your success rate. This is one of our study that we compared the type of fixation materials, including the screw and the endo button, and definitely screw was better than the buttons, but the French authors will not be happy with this, and they didn't cite this paper that much, I know. There are many issues in terms of the Latarjet procedure, why it fails, and also some complications, but the most problem is the coracoid graft problem. So you may get a fracture in your coracoid or very severe osteolysis, especially on the upper part of the glenoid, or in some cases the screw pull outs. stiffness, osteoarthritis, blah, blah, blah. There are many, many risk factors. So now nowadays, bone block techniques become a little bit, especially in North America, now it become very popular. I know the distal tibia is the best fit geometry to the glenoid parts that you can use it. So the left side is, we say, in the Bankart or Bankart remplissage. If it's more than 15-20, you can do bone graft. But what do you do with the subcritical bone loss? I started to perform dynamic anterior stabilization procedure for the subcortical bone loss. What is dynamic anterior stabilization? Dynamic anterior stabilization is the transfer of the long head of biceps from its original place to anterior part of the glenoid. So this is a kind of, like, I cannot say Latarjet equivalent, but it also has an seat belt effect and hammock effect that may also increase your practice. So the first time it was in 2017 described by Lederman and the friends. They have very bad results. And they figured out why it is bad results, because the only putting the biceps tendon just for the anterior of the glenoid doesn't make a strong block for anterior dislocations. Then it was modified as remplissage plus dynamic anterior stabilization. Now, remplissage DAS plus Bankart repair is the best solution for subcritical bone loss. So it has, as I mentioned, sling effect, smaller neurovascular, neurological damage, and there is no any issues about the graft, which is good, to be honest. So Popescu is a good friend of mine. He's from Poland. He's a shoulder surgeon. He is also working in this dynamic anterior stabilization, and this it's really simple, safer regarding the arthroscopic Latarjet, but don't forget to put the remplissage. So this is another of my case I do in the V-chair position. It's a little bit like fast. I'm sorry, just want to show the philosophy, what I'm doing. I'm not that fast surgeon, so I wish. So this is a little long head of biceps tendon, and he has a slap lesion. Luckily, that I can sacrifice the biceps tendon. So this is the heel sucks. First I did an remplissage for that case, and then I go into the joint. I put my first anchor not for dynamic anterior stabilization, just for Bankart repair. So I repair my Bankart first, and then I do my biceps tenotomy. I take the biceps out of an portal. I do my Korokov sutures, as you see here. I prepare it, and then I put it back inside the joint. And then I put my Riesinger rod from the posterior, just make a hole in the middle of the subscapularis tendon. And then when I dilatate the subscapularis tendon split, I just make the suture management, as you see. And then I just pull from back to the, this is the glenoid. And I put my anchor, and at the end, remplissage, biceps effect, and also the Bankart repair. This is slower. You will gonna see just the sling effect. You can see. Look at that. Look at the biceps tendon just in front of the subscapularis tendon has very good push of the humeral head. Literally, if we want to deal with the defect with the surgery, this side, we need to think about the both side, the humeral side and the glenoid side. The humeral side, if there is like more than 40 or 50%, sometimes like according to the chronic fixed dislocations, we need to prefer go with the arthroplasty sometimes. So it is also an arthroplasty candidate if it has a huge humeral defect, or if it's like 25 to 40%, we need to augment this defect with an allograft, sometimes remplissage, but less than 25, we need to go and check the glenoid part to do it. So this is a brief of my talk in terms of the treatment options. Less than 10%, if it's on track, I go with the Bankart repair isolated. less than 10% off track or peripheral on track that I mentioned intraoperatively, I do Bankar repair and massage plus minus dynamic anterior stabilization. If I have subcritical bone loss from 10 to 15, I do dynamic anterior stabilization. And if I have 15% of and more glenoid bone loss, I do letargy or bone block. So this is one of our cases that we published when I was doing my fellowship at Hopkins. It's an anterior lock dislocation, and you see we treated it with a reverse arthroplasty. So it has no bones, it has no muscles, no tendons. Sometimes we can operate these kind of bad issues, to be honest. So this is what I recommend. So just to sum up, all decisions making should be case sensitive. In last week, Dr. Alan Gatgood, he mentioned about individualized surgical treatment and options. So I definitely agree with that concept. So if you want to make a good job in terms of all population, but also we are dealing with professional, we need to decide individually, each by each, and spend some time particularly to check the patients, because there are many risk factors that should be considered just before we are doing. ZMRI is also recommended in good collaboration with the radiology department. Please be aware of all the hidden lesions just before you fix it. Thank you very much for your time.